Hi everyone, and welcome to our module on cerebral aneurysms. An aneurysm is a weakness in the vessel wall of a blood vessel that causes abnormal dilation, and aneurysms can rupture. And when the aneurysms occur in the brain, they can rupture and cause brain damage, and they can obviously be life-threatening and very serious. There are two types of cerebral aneurysms you should know about as a medical student. The first type are the saccular or berry aneurysms, and these are the more common aneurysms. So in this case, there's a sac or an outgrowth of a blood vessel from a weak vessel wall, and because it looks like a sac, they're called saccular, and it also looks like a berry, so they're called berry. And these occur in the large vessels of the circle of Willis, and when they rupture, they cause subarachnoid hemorrhage. The other type are called Charcot-Bouchard aneurysms. These are tiny microaneurysms, usually of a branch of the lenticulostriate artery, and they can rupture and bleed in patients with severe hypertension. In many ways, they're analogous to lacunar strokes. When patients with severe hypertension have an obstruction of a small blood vessel, that gives them a lacunar stroke. When they have a rupture of a small blood vessel, it's usually a Charcot-Bouchard aneurysm. There are some medical conditions and other patient factors that have well-established associations with berry aneurysms, and you should know these for your boards because they often come up in questions. The first one is adult polycystic kidney disease, which I talk about in detail in the renal section. Patients who have this condition often die from ruptured berry aneurysms. Ehlers-Danlos syndrome, which is a connective tissue disorder, is associated with berry aneurysms. So is coarctation of the aorta. And the way I've always remembered this is that patients with a coarctation have an abnormal aorta, so it makes sense that they may also have abnormal blood vessels in their brain. Older patients are more likely to develop berry aneurysms, so are patients who have hypertension or patients who smoke. And then finally, in terms of ethnicity, African Americans are one group that tend to have higher rates of formation of berry aneurysms. So when berry aneurysms, the large aneurysms, rupture, they give people a condition called a subarachnoid hemorrhage. This is where they bleed into the CSF space. We'll talk more about that in a little bit. Neurosymptoms are rare in this condition. What they usually get is a headache, so we'll talk about that in the next slide. And then when one of those microaneurysms ruptures from hypertension, people get a hemorrhagic stroke, and the symptoms are based on the site of the bleeding. So let's talk about subarachnoid hemorrhage. This is bleeding into the space between the arachnoid and pia mater, and it's very high yield to remember that space for your board exams. And over here on the right side of the screen is a CT scan of someone who has a subarachnoid hemorrhage. And what you can see is white material between the lobes of the brain, and that is blood. And it tracks along the lobes of the brain. It often surrounds the center here and tracks down to the bottom. And you should get very used to identifying CT scans like this because you're often shown them on your board exams. Patients who have subarachnoid hemorrhage classically describe the symptoms as the worst headache of my life. They have the sudden onset of a very severe headache. They can have fever and nuchal rigidity. Nuchal rigidity is rigidity in the back of the neck. It's hard to flex the neck. You can also see fever and nuchal rigidity in meningitis, but those patients won't complain of a sudden onset headache. CT scan is usually diagnostic, but there's a small proportion of patients who have a normal CT scan. And in those patients, if you have a high clinical suspicion, you can do a spinal tap, and you'll see what's called xanthochromia, and this is a yellowish discoloration of the cerebrospinal fluid, and that tells you that there is a subarachnoid hemorrhage in someone who may have a normal CT scan. And importantly, although there's bleeding into the brain, there are no focal deficits here because the bleeding is not into the lobes of the brain, so you won't see things like weakness and sensory deficits or speech problem and other things we associate with bleeding into the lobes of the brain themselves. The way you treat a subarachnoid hemorrhage is with a neurosurgical procedure called clipping, or there's another one called endovascular coiling, and both of these stop the bleeding. But you should know that rebleeding is common, and patients who have a subarachnoid hemorrhage usually go to a neurointensive care unit where they're watched closely because there is risk that the aneurysm will begin to bleed again. They also commonly have a problem called vasospasm, so the blood that is in the brain can trigger vasospasm and cause worsening neurosymptoms. And the way this often presents is that a patient survives a subarachnoid hemorrhage, but a few days later they have a focal neurodeficit, and what's happening is their blood vessels are vasospasming. There is a calcium channel blocker called nimodipine that's given to patients with subarachnoid hemorrhage. It's been shown to improve outcomes, but the mechanism is unclear. Some people think because it's a calcium channel blocker it may prevent vasospasm, but it's not been shown that that's definitely the mechanism of its benefit. So let's talk about where these berry aneurysms occur. They like to occur at branch points, and the most common place they occur is the anterior communicating artery. So that's this small artery right up here at the top of the circle of Willis. The second most common point is in the posterior communicating artery, usually right here after the internal carotid enters the posterior communicating artery. So you can remember that the anterior communicating artery is most common, and second most common is posterior communicating artery. Now, normally these aneurysms are asymptomatic until they rupture and cause a subarachnoid hemorrhage, but sometimes if they're very large and unruptured, just the aneurysm itself can cause symptoms, and in those cases the symptoms depend on where the aneurysm is located. So an ACOM aneurysm will cause headaches, and it will classically give a specific visual field defect called bitemporal hemianopsia. So bitemporal hemianopsia is when the patient loses vision on the outer portions, the temple portions of both eyes. So they can't see on the outside of both eyes. And that happens when anything compresses the optic chiasm. Aneurysms can do this, like the anterior communicating artery aneurysms, and also pituitary tumors can do this. And the way I think of this is just picture these black portions of the eye being pushed outward by something in the middle of the eye where the optic chiasm is, and that can be a pituitary tumor or an aneurysm. Those are the things that cause bitemporal hemianopsia. Posterior communicating aneurysms, on the other hand, if they haven't ruptured but are just causing symptoms from a large aneurysm, will give a unilateral headache, because remember that drawing of the circle of Willis, they're on one side or the other, and they can sometimes cause eye pain. And then the other classic finding of a PCOM aneurysm is a cranial nerve 3 palsy. So in this case, the eye will be down and out, meaning it's pulled down and outwards. There will be ptosis, meaning there's drooping of the eyelid, and the pupil will be dilated and non-reactive to light. When someone has a cranial nerve 3 palsy, we often ask if the pupil is spared. And what do I mean by that? We mean, is the pupil normal and not dilated? If the pupil is spared, it means the lesion is not an aneurysm. And let me explain that. The pupillary constrictors are easily compressed in the subarachnoid space by a mass lesion. So if there is an aneurysm, it will compress the pupillary constrictors and dilate the pupil. However, if the pupil is spared, this usually means they have a common palsy associated with diabetes. There's ischemic neuropathy of cranial nerve 3. This is a small vessel disease, and it typically only affects the motor fibers to the third cranial nerve. It doesn't affect the pupillary dilator fibers. This can sometimes be painful, and it usually spontaneously resolves. So this is called the rule of the pupil. And when you see a cranial nerve 3 palsy, one of the first things you want to do is see if the pupil is dilated or not. If it is dilated, you need to be very concerned that that patient could have an aneurysm or other mass lesion inside the brain. For the last slide here, I'll just mention Charcot-Bouchard aneurysms in a little more detail. As I said before, they are microaneurysms of small branches of the lenticulostriate arteries, which come off the middle cerebral artery. They rupture and cause bleeding into the basal ganglia and thalamus, which are common locations of intracerebral bleeding in patients with severe hypertension. And rupture of these microaneurysms is believed to be the origin of hypertensive intracerebral hemorrhage. And that concludes our module on cerebral aneurysms.